Thanks very much, and hopefully the slides will show up. There we go. It's, of course, a pleasure to come back and talk here. Really exciting that everybody could be together again in person after the long time of the pandemic when we weren't traveling. And this is such an exciting area to talk about. I will say that I was given a lot of abstracts and papers to talk about, so it may take a little more than my allotted time, but I'm going to try and keep to my time. It's just there were a lot of topics. So it is really exciting. It's the next generation in delivery of chemotherapy and toxins to breast cancer and many other malignancies. Much more efficient way of delivering treatment, and in most cases, I think, with less overall toxicity. As you can see here, there's a number of different antibody drug conjugates. Some are, long approved, like TDM1, our first generation ADC. And then we have our next generation ADCs in the next group, TDXD, sacituzumab, and most recently Dato-DXd, and then a whole host of novel agents that are in early phase trials, such as SKB264 and patritumab, and we'll talk about two others that just have toxicity and early efficacy data. Disitamab is sort of a more, probably a dead ADC at the moment, but it's still being studied. It just causes a lot of neuropathy. So that brings us to the next question. Antibody drug conjugates are composed of an antibody, and the targets are listed here. With trastuzumab, of course, a very common target, TROP2 for a number of different of ADCs, HER3, a novel target, and then there are other targets as well, as I'll show you in a moment, B7H4. The idea is to choose a target that's more expressed on the tumor cells than on the normal tissues, and that can be quite a challenge. And then the linkers have really changed. So you can see that TDM1 has a linker of thioether, and as we progressed on, we have hydrolyzable linkers that are often tetrapeptide based, but not all. They vary depending on the company that's manufacturing the different ADCs, but the idea here is that these are cleavable linkers so that the payload can actually be released more easily within the tumor cell. And then the second part is of these novel ADCs, so next generation ADCs as they're called, is the payload. And so you want to have a payload that actually has toxicity that's not cumulative over time. And with the exception of the auristatins, you can see with disitamab, there's an auristatin MMAE, the topoisomerase inhibitors don't cause neuropathy, which is a big plus because neuropathy can be very difficult and is cumulative. There is actually one ADC that's not listed here, ADARX788, which is an ADC, HER2-based ADC, but it has a MMAE that doesn't cause neurotoxicity, which is really interesting. So it's MMAE. Instead of MMAE, it's MMAF. And so that one's actually in early studies in HER2 positive and HER2 low disease. So quite interesting. And the whole idea here is that, we want these drugs to be able to be used in sequence. We want to understand resistance. And so trying to have different payloads and different targets is important. We ended up having all our successful drugs with similar payloads. So that's part of the problem. But one of the unique parts of these payloads is that they're membrane permeable. You can see that below. Turns out that they generally are fairly effective even when they don't have very membrane permeable drugs, like the MMAEs. It says yes here, but they're not quite as membrane permeable. This allows a bystander effect, as I'll show you a cartoon about in a moment, and so that the drug can leak out of the tumor cell and kill neighboring tumor cells that may not express the target, which is important. The other thing that just to pay attention to on this slide is the drug to antibody ratio. So TDM1 had a 3.5 to 1 drug to antibody ratio. That's the payload, the number of payloads that you can attach to the antibody. You can see that the ones that are approved, TDXD and sacituzumab, are in this 7.5 to 8 to 1. But there are actually very effective drugs like datopotamab. I'll show you the teeny bit of early data we have on that, where they have a low drug to antibody ratio but are still very effective. So it's not, the only story is not drug to antibody ratio. There's many parts of this story that we don't completely understand. So this is the idea of the bystander effect, where the antibody drug conjugate binds to the receptor, is internalized into the cancer cell, the linker is broken or hydrolyzed, hopefully, and the cell eventually dies. But meanwhile, you have the payload able to leak out of the cell and kill neighboring tumor cells, so the so-called bystander effect, which also leads to off-target toxicity, so that's important to understand as well. So let's talk about the data that I have, all of these data to talk about. So first is trastuzumab deruxtecan in HER2-positive metastatic breast cancer. So DESTINY-Breast03 updated data published in Lancet Oncology this year, shortly after it was presented, which is always great. And of course, this study is remarkable in that it showed such a dramatic improvement in progression-free survival with T-DXd compared to T-DM1, largely given in the third-line setting, median of 2 lines of prior therapy. About 60% had prior pertuzumab, 70% visceral disease, half of the patients hormone receptor positive disease, and 15% with controlled brain mets, so treated brain mets. One of the big questions, of course, is does the progression-free survival, the updated primary endpoint, impacted by subsequent therapies? And I think most importantly, would overall survival be impacted by subsequent therapies? As you can see, overall survival continues to be significantly better in patients receiving T-DXd, hazard ratio 0.64, highly significant, and the curves separate early and stay separated, similar to the progression-free survival. If you look at the anti-cancer therapies in the post-trial setting, about a third of the patients received T-DM1, but very few patients in the T-DM1 arm received T-DXd. So this is a very clean study, relatively, suggesting certainly that T-DM1 improves outcome. What we don't know is, could you give T-DM1 first and still get the benefit of T-DXd? And so that was the point of DESTINY-Breast02. But obviously, if you have better outcome, you want to use the drug as early as possible. In terms of toxicities, what was fascinating in DB03, no new toxicities, nausea the most common toxicity from T-DXd, sometimes quite delayed. But the interesting thing was that the interstitial lung disease rate at 15%, 12 to 15% reported by all studies, but there were no grade 4 or 5 events. We have no idea why that's the case. It's the only study where there are no deaths from ILD from T-DXd. So maybe it's, can't be just exposure to prior trastuzumab, because they did see grade 5 events in DB02 that I'll show you in just a moment. So fascinating and practice-changing data. They also looked at the small number of patients who had brain metastases versus those who didn't, and you can see the progression-free survival is dramatically better in patients who received T-DXd versus T-DM1, 15 versus 3 months. Pretty amazing difference here. I mean, we really rarely see anything like this in any field of cancer. And then you can see at the bottom some data, although there's a little thing that says chat there. I don't know why. Okay, I think I'm going to make it go away. But you can see at the bottom the brain mets at baseline in terms of the patients and the intracranial response rate, which was so dramatically better in patients who received T-DXd versus T-DM1. At ESMO this year, Sarah Hurwitz presented data that pooled all of the patients from DESTINY-Breast01, which was the first phase 1 expansion study, DESTINY-Breast02 and 03, 02 being patients who were treated in the third or greater line setting, all of whom received prior T-DM1. So heavily pretreated patient population. And they looked at the patients who had treated or stable brain mets and those who had untreated and active brain mets that were allowed onto the studies later once they started seeing activity in brain metastases. And you can see how dramatically better the response is with T-DXd versus any of the other treatments. And the green part are all the different treatments in the different trials, DB01, 2, and 3, right? So it could have been a lapatinib-based treatment, TDM1, or in the DB01 trial, there was no comparator. So I think pretty impressive in terms of the response in brain metastases, and it appears to be quite durable by this PFS, even in patients with treated and stable brain mets. There is some other data which I thought I would just share with you. The Tuxedo-1 trial, which looked at patients with newly diagnosed brain metastases or progression after prior treatment. Everybody had prior HP, and everybody could have had prior TDM1. And they saw a remarkable objective response rate shown here by the RANO-BM criteria, and in the 15% of 15 patients where they could see a response, it was 73% with a progression-free survival of 14 months. That was published in Nature Medicine. And then ROSETTE-BM was a retrospective review of patients who had either brain mets or leptomeningeal disease. And I've summarized, you can see what the responses were, very nice. And the little L's are the patients with leptomeningeal disease, where we really struggle for any treatment that works, particularly in patients where this occurs late in the course of treatment. 19 patients with LMD had a 12-month PFS of 61% and a 12-month overall survival of 81%. And the response in patients with brain metastases was quite similar to what we've seen in the other trials with a similar PFS that I think it certainly rivals anything we've seen before. DESTINY-Breast02 evaluated TDXD compared to treatment of physician choice in patients who had all received prior TDM1. So this looks at the question of, can an ADC work after an ADC, the sort of sequential question we're struggling with in non-HER2 positive disease. The treatment of physician choice was either lapatinib or trastuzumab with capecitabine in all groups. And as you can see, progression-free survival was just dramatically better. I mean, 6.9 to 17.8 months, hazard ratio 0.36, and median overall survival also markedly improved. I mean, that's a 13-month absolute improvement, a year difference in overall survival in patients who have access to TDXD. So I think these data also, encouraged patients who haven't had it in the second line setting that you could give TDXD in the later line setting, and that you could see efficacy in a patient who had received prior antibody drug conjugate when it's TDM1 and progressed and would still get a benefit. Now the question is, what do you do first? And I think in general we would give the most effective drug first, because that's what we always do, and that tends to result in a better overall survival and better disease control and quality of life for our patients. But certainly it works later. What we don't know from any of this data is whether TDM1 works after TDXD, and that's going to require real-world data with more patients treated in the metastatic setting. You can see 0.5% grade 5 toxicity. Death from ILD is a real risk with TDXD, although the numbers are very small. Most events are grade 1 and 2. It's incredibly important to follow the guidelines for managing the interstitial lung disease that I'll show you in just a moment. So then at ASCO this year, Ian Kropp presented a pooled analysis of TDXD based on age. Again, they looked at DB01, DB02, and DB03 and divided patients between being under 65 or 65 or older. And then I always like it when they include the patients who are actually really old, which is 75 or older, since 65 now is newly young. So median progression-free survival, you can see based on the 3 different trials with light blue younger and dark blue older patients, looks relatively similar. The landmark overall survival at 12 months was reported because many of the survival endpoints haven't been reached based on age, and that also looks quite good. That's in the bottom left-hand corner. And then if you looked at median overall survival, you can see where it wasn't reached, but looks great. And they didn't have enough patients who were 75 or older, but basically they showed the same thing in the much older patient population versus 65 or older, more grade 3 or greater treatment emergent adverse events. And this has been shown in every single study that's been done. CDK4/6 inhibitors, all the antibody drug conjugates, any chemo drug. If you get older, although your benefit may be the same, your toxicity risk is higher. So I think that that's important. We need to monitor patients very carefully and have a low threshold for dose reducing, because you can always go back up on the dose when you're not in a clinical trial if that's appropriate. And supportive care, I think, is particularly important. The rates of ILD pneumonitis were higher in patients who were older as well. So these are patients where, you might be thinking of getting less frequent scans, they're older, but you actually want to get a non-contrast CT scan earlier in those patients and follow them more closely in the first year where they could get ILD, since that can be a fatal complication. So TDXD is now firmly established in the second-line setting. The HER2 climb regimen with tucatinib or another, if you don't have access to tucatinib, another oral TKI. In the second-line setting in somebody with active CNS disease, more than just a single lesion. Otherwise, we tend to use it in the third-line setting, and really because it's a little bit harder for patients to tolerate compared to TDXD. It's just an oral regimen with diarrhea, and they're just sort of managing up and down their hand-foot syndrome, etc. And then, of course, we still have lots of options, and understanding the sequencing of newer ADCs is a big challenge for the future. There are a number of ongoing trials looking at TDXD as post-neoadjuvant therapy, so rivaling Catherine, and then in the neoadjuvant setting, as well as first-line treatment in the metastatic setting, as well as looking in more detail in patients with brain metastases. What about HER2 low disease? Well, T-DXd, as you know, is approved in the a number of countries for HER2 low metastatic breast cancer based on the Destiny Breast 04 trial that showed remarkable efficacy. And this data was updated at ESMO this year. So patients were eligible who had hormone receptor positive, centrally confirmed HER2 low disease. And then 58 patients were enrolled in an exploratory cohort who had hormone receptor negative HER2 low disease. Patients were also eligible if they received 1 or 2 lines of prior chemo. The median number of prior chemo lines was 1. 557 patients were randomized 2-to-1 to receive T-DXd or treatment of physician choice. The median follow-up at the primary analysis was 18 months, and then they did so I'm an author on this also, did an updated data cutoff with a median follow-up now of 32 months. 60 to 70% of patients had received a prior CDK4/6 inhibitor, so not all, and 70% had liver metastases, which we see now in all of these trials, except for Tropics, because that trial treated patients later in the course of disease, so almost everybody had visceral mets. 50% of patients had eribulin, and across all of the trials, Dato, T-DXd, sacituzumab, 50% of the patients received eribulin. So we seem to all be thinking the same way. So this is the updated overall survival, and this, of course, doesn't depend on whether it's investigator or centrally determined, but you can see the primary analysis and then the updated analysis, which continues to show a marked improvement in overall survival, going from 17.6 to 23.9 months. And then in all patients, you're just adding 58 patients with hormone receptor negative disease. The difference is very similar with the identical hazard ratio. And then updated progression-free survival. Now, the primary analysis, so they talk about this is the final IDFS, right? But that's just protocol specified, and then we keep doing the, on and on, because there are still patients who haven't progressed. But you don't go back and do blinded analysis because you've already finished it. So this is investigator assessed. So the hazard ratios are completely different than what was reported. So in the primary analysis, the hazard ratios are 0.51. Here you're seeing 0.37 from the primary analysis with investigators, and the difference is almost identical now with the updated analysis, as you would expect, and all patients, again, no different. So what about the subgroup analyses? And I show these just to show that although the little dotted line isn't visible to you, you can see that all of the little triangles are to the left of one and line up very nicely. So there was no subgroup that did or did not benefit more or less. Adverse events, very similar. Nausea, the most common toxicity. And the only thing that they showed that was different was one additional patient actually died from interstitial pneumonitis. That patient already had ILD and pneumonitis in the prior report, so it was reported, but moved from having grade 3 to grade 5 event, unfortunately. So there were no ILD events with longer follow-up, no new ILD events. Cardiac toxicity is quite minimal. Let's see, it keeps popping up with little things on my screen. Okay, so what do we know about ILD? This is a pooled analysis published in 2022. The overall incidence about 15%, identical to the trials, 12 to 15%, but almost 90% of patients have their first event in the first year. However, there have been occasional cases of late onset ILD, so we shouldn't not ignore findings of ground glass opacity. They should all be treated the same way. The risk is higher in older patients, in patients who are Japanese or Korean, probably. They didn't look at that. Patients with lung comorbidities, and in particular, patients who have decreased renal function are at higher risk as well. Time since diagnosis is also a issue. So patients who are farther out, more heavily pretreated, have a higher risk as well. And I've definitely seen that in clinical practice. We only use 5.4 milligrams per kilogram or lower, so that's not an issue, but hypoxia also was a risk. So for patients who have asymptomatic ground glass opacities, we hold drug. I give 0.5 milligrams per kilogram of steroids, repeat the non-contrast CT in 3 weeks. Everybody reduces their ground glass opacities on this approach. And sometimes we taper a little before we get to the 3 weeks because people don't like being on steroids. And then we restart the drug. If it recurs, then you need, or it takes longer to get better, then you need to dose reduce, but you can still try giving the drug. If patients have symptoms from T-DXd, you have to permanently discontinue. We'll present data at ESMO Breast this year on more data about retreatment after occurrence of grade 1 ILD. Interestingly, this was very difficult to capture in DB04. You know, we knew our patients at our institution, and we're doing our own institution analysis now of everybody who had ground glass opacities and what happened to them. But we reported this at ESMO Breast this year. 6 patients were retreated after resolution, even though a lot more patients had grade 1 ILD, so it doesn't make a whole lot of sense. But one patient had a second event, that was my patient, which then became grade 2, and she had to permanently discontinue drug. But she didn't progress after grade 2. So definitely you can retreat. Patients can stay on and enjoy the benefits of drug, but you have to follow these patients very carefully. So I was asked to just do a little bit more detailed presentation about the toxicities. We presented at ESMO Breast this year, median time to first onset and median duration of first event. Most of the toxicities that you care about, other than ILD, occur in the first cycle with T-DXd. So patients going to get nausea, they get it right away. It generally occurs within the first 3 days, and then it can last a long time. So the median duration of first event was 10 days, so it can last, a median means some people are having nausea for the whole 3 weeks. So it's really important to give adequate pre-medications and rescue medication. We give everybody olanzapine at 2.5 milligrams. Just recently published data from Jyoti Bajpai in the Lancet Oncology just 2 days ago. And then GI toxicities other than that are really quite uncommon, and bone marrow toxicity is quite uncommon. Anemia you see a little bit more of, but I have to say I had a patient on DB01 who was on T-DXd for 4 years and was never even anemic. I mean, these are the patients occasionally patients will get neutropenic. You can give them short-acting growth factor, they do fine. I occasionally dose reduce if somebody's thrombocytopenic, but mostly their counts look normal as if they're not getting a drug, which is amazing. So we recommend that patients get a 3-drug pre-medication, then you can tailor down if they don't have nausea. And then, of course, olanzapine for rescue, as I mentioned, along with the standard triplet drugs. Some patients didn't receive prophylaxis, which would probably increase their toxicity. In terms of age, the toxicity profile, of course, was presented in a pooled analysis, but median progression-free survival was better over TPC in all patients, regardless of age, in the HER2 low group, not just in the HER2 positive group. And you can see, again, the grade 3 or greater drug-related treatment-emergent adverse events were just a little bit higher. And, they weren't that much higher. So in some ways, the HER2 positive group had more toxicity than this group, about 40% versus 48% in the younger and older patients. So a big question comes up with T-DXd about whether or not use can be expanded. The DAISY trial published last year, 2 years ago now, showed that the response rates were much better if you have HER2 overexpressing disease. Next, much better in HER2 low. If you were HER2 zero, the responses existed, but they were much less than in patients who have HER2 low or positive disease. And then progression-free survival is progressively shorter based on how much HER2 expression you have. 11, 7, 4 months. In the ER negative HER2 zero patients, the PFS was 2 months. So those patients all progressed at their first scan. So we don't really know that T-DXd is going to work in this true triple negative group, but it's being studied in HR positive disease in Destiny Breast 06, randomizing 850 patients in the first line setting, has completed accrual. 150 of those patients have ultra low disease, so less than 1+, but more than 0. We'll see what that shows up in terms of what that does to our treatment of patients in the first line setting. But these patients will have become resistant to endocrine therapy, and many have received a CDK4/6 inhibitor, but it's not required, and again, central confirmation. Destiny Breast 08 was presented at San Antonio this year by Komal Javeri. This is an exploratory trial looking at different combinations of T-DXd. I have to say, I'm not really clear why they're doing this trial. It's not clear to me that the endpoint will ever be something that we can incorporate well into trials. It was never a question about the safety of giving endocrine therapy with T-DXd. It's really to allow the next step in patients who, these are HER2 low, but where will this be used most? In the post neoadjuvant therapy HER2 positive group of patients, because T-DXd is likely to beat T-DM1 in the Destiny Breast trial that's looking at post neoadjuvant therapy with residual disease. So I'm not exactly sure. I mean, are we going to add endocrine therapy in all patients? It's unclear. In any case, they only had 21 and 20 patients with anastrozole and fulvestrant. And you can see that the adverse events were largely what you would expect with TDXT alone. No difference based on the on the type of endocrine therapy, and no very low rates of interstitial lung disease. As you can see, 5 in one group, all grade 2. Nobody progressed or died from ILD. And then they also looked at response, which is what you would expect from TDXT. So I think that we can confirm that it seems reasonably safe to combine TDXT with endocrine therapy, but we don't really know, who would benefit from this, where we're going to add toxicity. Now, what about sacituzumab govitecan? Let's talk about our TROP2 ADCs now. So sacituzumab, first-in-class TROP2-directed antibody-drug conjugate, showed dramatic improvement in progression-free and overall survival for metastatic triple-negative breast cancer. These patients were heavily pretreated with a median of 3 to 4 lines of prior chemotherapy, and yet they still had this dramatic benefit. There's a lot of neutropenia and some diarrhea with sacituzumab, but actually, as I've been treating patients earlier and earlier in the course of their metastatic triple-negative course, I see less neutropenia up front, some patients going many months before they need growth factors or not needing them at all. And also we see less diarrhea overall as well. Once we required that people have an ANC of 1500 at the start of each cycle in the clinical trials, we stopped seeing febrile neutropenia in most patients. But if a patient has diarrhea and they're neutropenic, they are at risk. It's really important to treat the neutropenia if they're having any mucosal damage like diarrhea, because those are the kinds of patients who could have a more high-risk toxicity. There's no neuropathy and no interstitial lung disease. Sacituzumab also is tested in TROPiCS-02 for hormone receptor positive HER2 negative disease, showing a significant improvement in progression-free survival. 3 times as many patients were free from progression at 1 year with sacituzumab versus those who received treatment of physician choice. And overall survival was also significantly improved. There were no new toxicity signals compared to the triple-negative study ASCENT. These patients who were enrolled in TROPiCS had received 3 lines of prior chemotherapy, and 98% of them had visceral metastases. So they were a very heavily pretreated, high disease burden group of patients. We looked at also PFS and OS by TROP2 expression level and HER2 IHC status. There was no difference based on being high or lower expressor of TROP2, and since TROP2 is expressed in almost all tumors, we didn't really have the power to look at TROP2 0, and then HER2 status, as expected, had no impact on outcome. We also saw increase in response, and this just summarizes the safety data. Again, neutropenia, the most common toxicity, 52% at grade 3 or greater in patients heavily pretreated, and 10% with grade 3 diarrhea. We didn't really see grade 4 diarrhea. So we were really interested in safety outcomes based on UGT1A1 polymorphism status because, as you know, SN38 is metabolized by UGT1A1 and there are known polymorphisms. The STAR28 homozygous polymorphism is associated with absent metabolism of irinotecan and therefore SN38, the payload for sacituzumab. And as you can see, that's only 13 or 9% of patients, so it's not so common. We don't really know the ethnic and racial variations well in this polymorphism. Those patients who had absent metabolism had more neutropenia and notably more diarrhea than patients who did not, who had a more active metabolism. There's sort of a general trend, so if you're star 1, star 28, you have a little more, but the patients who we really care about in clinic are the star 28 homozygotes. So treatment discontinuation was more common due to adverse events in the star 28 homozygous group. So I think the critical aspect here is if patients do have diarrhea, it's a really good idea to dose reduce. You want to hold drug, treat the diarrhea, certainly treat neutropenia, and then dose reduce first, rather than, because these patients, if they have a lot of diarrhea, they're not metabolizing the drug well. And so you're going to get the same bang for the buck by using lower drug levels. There are a number of trials going on looking at sacituzumab versus chemotherapy in the first-line setting with or without pembrolizumab in patients with triple-negative disease. We have ASCENT-07 enrolling patients as first-line chemotherapy in HR-positive disease. There are 2 post-neoadjuvant trials. The one probably that will give us the most information is in triple-negative disease, ASCENT-05, which is currently accruing patients. And then there's also looking at sacituzumab with pembro in patients who have PD-L1 negative disease as well. So the last trial where we have phase 3 data is datopotamab deruxtecan. This is the next TROP2 ADC, lower antibody drug ratio, but very efficacious in phase 1-2 trials. So TROPION-Breast01 randomized patients who'd received 1 to 2 prior chemotherapies for metastatic hormone receptor positive disease and were refractory to endocrine therapy to receive Dato-DXd or treatment of physician choice. With a primary endpoint of PFS and OS. And the median number of lines of chemotherapy that these patients received was 1, very similar to what we saw in DB04. Median follow-up now is 11 months. Progression-free survival was significantly improved, interestingly, almost identical to what we saw in the Tropics trial. Even though these patients were less heavily pretreated, the absolute difference in PFS was relatively similar, which was interesting, and the hazard ratios are identical. So TROP2 ADCs are slightly different than our HER2 ADCs. We're seeing like maybe a little bit less dramatic improvement, but still a significant improvement. So two big differences in these classes of drugs, even though you have a same payload, T-DXd and Dato-DXd. Time to subsequent therapy was also delayed by 3.2 months median with a hazard ratio of 0.53. They looked at various subgroups that Aditya presented on behalf of our group at San Antonio this year, looking at prior duration of CDK4/6 inhibitors. Again, these patients are treated earlier in the course of therapy, and they saw an improvement in PFS regardless of whether or not patients had more endocrine resistant or not disease based on CDK4/6 exposure. Also, there was a small number of patients, 35 and 23, who had brain mets that were controlled at baseline. In that group of patients, the difference in PFS was very small, but it's hard because these are really tiny numbers. And in the larger group of patients, the difference was still 2.1 months. Hazard ratio was similar. In terms of safety, the drug causes stomatitis, but we had asked patients to use a steroid mouthwash similar to what we piloted in the SWISH study with everolimus and has been shown to really reduce aphthous ulcers from many of these drugs. And so obviously not everybody had access to it, not everybody used it, we didn't mandate it, but that led to any grade stomatitis of 50%, but only 6% with grade 3, which was markedly less than what was seen in the non-prophylaxis treated patients. And overall, there were less grade 3 or greater treatment-related adverse events and delay in deterioration of global health status, so that was good. Hematologic toxicity is modest and similar to sacituzumab. Dato-DXd causes hair loss in almost everybody. T-DXd causes hair loss in less people, but some people lose their hair, so you do have to warn them. There are a number of studies ongoing. We're awaiting overall survival from TROPION-Breast01. TROPION-Breast02 is a first-line study in patients who have relatively non-resistant triple-negative breast cancer. You have to be more than a year from your prior therapy or have de novo disease. And then there's a post-neoadjuvant study similar to sacituzumab, but with 3 arms, Dato-Durva, Dato, or standard care with Pembro and CAPE. There's a lot of interest in mechanisms of resistance to TROP2 ADCs, and certainly what's fallen out is that there's a sort of 2 main pathways. So mutation in the antibody binding site, so in the receptor, and then mutations that lead to a lack of efficacy of the payload. So it could be mutations in TOP1 if you have a topoisomerase inhibitor, or mutations in the receptor, TROP2, in the case of TROP2 ADCs. And this has been shown actually in one patient studied at Mass General. The patient's different organs had the different mutations. So the patient had both mutations there that led to resistance to sacituzumab. So there's a lot of interest in whether or not a patient who benefits from one ADC could benefit from another, and doesn't make a difference whether you vary the antibody or the payload. Number of different studies at ASCO 2023, we saw the first, these are all retrospective analyses of 35 patients, and what they saw, which was fascinating to me, was that most patients, as you would expect, have a better PFS with the first ADC, and that, I'll show you, has now been shown in a number of different retrospective studies. But there are some patients who have a better PFS with the second ADC. And I've seen this actually, one patient who received sacituzumab after T-DXd and had a longer PFS to sacituzumab, and I've seen the reverse as well. So this is where we really do need to understand these mechanisms of resistance so we can personalize therapy. So at ASCO, we saw data from the French group looking at sacituzumab followed by T-DXd versus T-DXd followed by sacituzumab. Again, these are retrospective analyses, so you have to take them with a big grain of salt. And what they saw was that the median PFS, One in blue there is HR positive with T-DXd, and green is HR negative with sacituzumab. You can see the various PFS. It's hard to say those are really different because the numbers are quite different, 100 versus 56. And then PFS2, as you would expect, is relatively short. So the conclusion here is that, if you give an ADC post-ADC with the same payload, the PFS is pretty short in most patients, and we really haven't identified which patients have a better outcome in this setting, and we need better information to do that. And you can see the therapeutic sequence in this setting. They saw better PFS when you went from SASI to T-DXd versus the reverse, but we have no idea what that really means in a prospective analysis. And then my junior faculty member, Laura Hubbard, did a retrospective multi-institutional cohort study at 5 centers, and again looked at patients who had hormone receptor positive or hormone receptor negative HER2 low disease, and looked at real-world PFS and real-world overall survival. So 56 patients, HR positive, HER2 low. Most of the patients received SASI followed by T-DXd, here you can see, and then we have some T-DXd SASI, but these patients were treated in longer ago, I think, just because of when T-DXd became available. But you can see ADC1 with SASI, here's the PFS versus ADC2. Again, very similar data. Occasional patients have a better PFS with the second ADC. Look at this patient, very far out. But most of the patients have a shorter PFS with the second ADC. And we don't know about sequencing because some of these patients had intervening therapies between the ADCs, just under 50% did in both groups. So it may be that there's some hypothesis that if you have intervening therapy, you can upregulate your receptor again and respond better, but we don't know that that's true. In HR negative disease, almost everybody received SASI first. Again, some patients had very good PFS with their second ADC. As you can see here, there's a few patients who had really good progression-free survival with T-DXd after sacituzumab. So very interesting data for our patients. And then the last study that I'm going to mention is, again, another multi-institutional experience, but they also looked at biomarkers. And again, you can see this shorter, they had much shorter PFS in their second ADC. And they also looked at whether change in antibody, change in payload made a difference. And I think that the numbers of patients in each group are just too small to really make an assessment, but this is the kind of evaluation we need to be doing over time. And then they did this fascinating study looking at TOP variants. And I think that, the genomic data looking at these TOP1 variants suggests that you can acquire payload resistance over time. But one of the patients who had acquired resistance had the best progression-free survival. So it's not really clear if there's enough heterogeneity that you're still seeing a benefit, even when somebody has what you would hypothesize would result in resistance to that antibody drug conjugate. So it's very interesting data. We clearly need more of it, but it's a start. There are 2 prospective studies planned in the US through our consortium, looking at T-DXd and Dato-DXd in sequencing, a trial called the TRADE-DXd trial, and then a sequencing study by my junior colleague, Laura Hubbard, looking at T-DXd and sacituzumab as more of a registry. HER3-DXd is the last DXd ADC we have, and this drug also developed by Daiichi is now in partnership with Merck. So we have AZ on one side and Merck on the other, a little battle there. And so there are planned studies now with this phase 3 studies that will go forward, and then I think sometime later this year. But Erica Hamilton presented data in a phase 2 study looking at patients with HR positive, triple negative disease, and then HER2 positive disease has also been studied, but they don't have enough patients in that cohort yet. But what they saw was very nice responses independent of HER3 expression and very durable. In terms of toxicity, again, nausea, which is characteristic of all of the deruxtecan ADCs. They didn't report alopecia. They did see a low rate of interstitial lung disease. Again, Dato-DXd has the lowest rate. We don't yet know for patritumab, but all of these 3 ADCs have been associated to some degree with interstitial lung disease. Patritumab deruxtecan, Dato has stomatitis, patritumab has thrombocytopenia. Not so common, but you see it. These are unique toxicities, unknown exactly why they're occurring with a similar payload. And then just to finish up, there's a few different novel ADCs that have been studied. The most important of these, I think, is SKB264, now known as MK2870. also a really easy name. So this study actually was developed by a company in China called Kalen, and now it's partnered with Merck. So Merck is developing this drug now, and plans 2 different phase 3 studies are already planned and written and going forward with this TROP2 ADC. So here you can see it's a topo-1 inhibitor, so it's very similar, belotecan. The DAR is very similar to sacituzumab, and it's an anti-TROP2 antibody. They've seen very nice responses, as you can see here in metastatic triple-negative disease at 42%. TROP2 high expression seems a little higher, and it's quite durable. And then looking at the overall survival, I think doesn't tell us a lot, but they do see stomatitis with this ADC, which is not seen with sacituzumab. So it's really fascinating. About 7% grade 3. They didn't use prophylaxis in this setting. And then they do see some grade 3 or greater thrombocytopenia as well. So we'll see how this goes forward in the phase 3 studies. Then 2 last ones, BL-BO1D1. This was studied in a dose escalation expansion trial. There's many of these studies going on in China. And it's an EGFR and HER3 bispecific antibody drug conjugate, and it has, again, a TOP1 inhibitor as its payload. Thankfully, there are some drugs which have different payloads, but they weren't presented in this last year. They're still in phase 1. So overall response was quite respective in the 3 different groups of patients, with about 23 to 38 patients in each group. So 31 up to 45% response, which was quite nice. And then in terms of toxicity, you can see the responses here in the waterfall plot. They see neutropenia, anemia, and more thrombocytopenia than we've seen in the other studies, and 2 deaths due to febrile neutropenia because they aren't using growth factors so much. They also saw stomatitis, 40% and 24% grade 2. So interesting. Now we're seeing a whole bunch of these with stomatitis, whereas we hadn't seen it at all in the first 2 approved ADCs. They saw benefit regardless of EGFR expression or tumor subtype, so this also will move forward. And then lastly, B7H4 antibody drug conjugate. So B7H4 is a glycoprotein in this superfamily called B7, highly expressed in tumors, low expression in normal tissues. This also has a topo-1 inhibitor payload, and they've seen very nice responses with this ADC, which at least has a new target. And they presented data at ESMO on triple-negative breast cancer. You can see the overall response was quite respective. Overall, in 28 patients, about 29%, including a dose escalation where they started at a very low dose. So they saw really nice responses at the higher doses in these patients. And the toxicity was quite modest. So we'll see where that one goes as well. So antibody drug conjugates, this is the new future for us in delivering chemotherapy to patients who need chemotherapy for breast cancer. Now, they're established in the metastatic setting in all now 4 subtypes of breast cancers that we treat, and are rapidly moving into the early stage setting where I think they're going to really change the outcome. We have used datopotamab deruxtecan, just 4 doses, as neoadjuvant therapy in our neoadjuvant I-SPY 2 trial with some patients who have path CRs with just 4 doses. So it's going to be really interesting to see what that data looks like overall. We've also given ARX788, this novel HER2 ADC, 4 doses, path CR in node-positive, HER2-positive breast cancer, and now we're looking at a novel antibody as well with remarkable responses. So I think that, we're on the verge of really using these new agents that have better toxicity profiles, although ones we have to be aware of, improving outcome for our patients with early-stage disease, and we're already improving outcome in the metastatic setting. Thanks very much.